in the community. So we're excited to have his presentation today. Again, we ask that you mute. If you do have a question, you can certainly unmute and ask, but we will have time at the end as well. So if you'd like to hold it till then. So we'll start with the next slide, I think.
Okay.
So what is Parkinson's disease, Dr. Weeks?
Oh, see you so can I advance the slides, or you have to do it?
Yeah, there you go.
So Parkinson's disease is the second most common neurodegenerative disease next to Alzheimer's disease. It's very common. By age 70, about 2 out of every 100 persons will have Parkinson's disease. But typically, the condition starts when people are in their 50s and 60s, yet you'll have unusual cases like Michael J. Fox, who developed his illness in his 30s, and other people may not develop symptoms until late into their 90s. It's complex, as you'll see during this talk, but the good news is it's quite treatable. So let's have the next slide. So how do we diagnose Parkinson's disease? Next slide, please. Interestingly, you can't see Parkinson's disease on a CAT scan or an MRI scan or a blood test. It's a clinical diagnosis. It's based on the examination that the physician does on the patient, finding abnormalities in movement. And that's why it's often called a movement disorder. That's the clinical diagnosis. We can go back to that prior slide. Pathologically, of course, if someone were to die and have an autopsy, you would see loss of pigmented neurons in the midbrain, and those nerve cells in the substantia nigra have a little inclusion called a Lewy body. But of course, these are things you cannot see during life. You can't see these things on MRI and CAT scans. These are strictly pathologic. Those are the pathologic findings that confirm the clinical diagnosis. Now we can go to the next slide. What are those abnormalities on examination to suggest the diagnosis of Parkinson's disease? Next slide, please. Oops, oh, the video isn't working here. Well, I have a series of videos. Unfortunately, it looks like this format isn't showing my videos. So this gentleman has a hand there shaking violently. The public associates Parkinson's disease with tremor. Most patients with Parkinson's disease do not have traumatic tremors like this video would have shown. In fact, in most cases, the tremor is rather subtle and intermittent, and about a quarter of patients with Parkinson's disease don't even have tremor. So if your whole conception of Parkinson's disease is tremor, you're missing the boat. Next slide, please. And the next couple of slides, unfortunately, the format that I sent you to these doesn't show what these are videos that show the very subtle tremors that people could have in their hand or in their foot. And it's often unilateral. Often it affects one side and not the other. Next slide, please. And patients on examination have a stiffness in their limbs. It's not arthritic stiffness. It's almost like a cogwheel sensation that's very typical of persons with Parkinson's disease. They become quite stiff. Once again, often worse on one side of the body than the other. Next slide, please. And movements are very slow. When people want to open and close their hands or do certain tests like moving their fingers quickly, it slows down tremendously in persons with Parkinson's disease. And that turns out to be a source of considerable disability, much more so than tremor. Next slide. Now, what about a masked face? You've heard the term masked face. It has nothing to do with wearing masks for COVID. Let's see the next slide. Because it turns out that that stiffness and slowness of movement often affects facial expression. And you could look at these folks and they have that particular blank stare, that sort of unhappy look that's not reflecting the fact that they're necessarily unhappy, but you have this diminished movement of the facial muscles that gives it this, what's medically called hypomania. So you can walk into a room and see this on somebody's face and say, gee, is this person Parkinsonian? Next slide, please. And of course, not everybody has every symptom. There's a typical abnormality of gait. People have trouble getting up out of a chair. They have to push with their hands. They take little short steps. They shuffle. They don't swing an arm, usually because Parkinson's is asymmetric. Often they swing one arm, but not the other arm. And they have trouble turning around, or maybe a stooped posture. It's a narrow base gait. It's quite typical. And of course, that could be disabling because it leads to unsteadiness and maybe falls. Next slide, please. So you've all heard the old saying, if you've seen one, you've seen them all. But if you've seen one person with Parkinson's disease, next, you've seen one person with Parkinson's disease. There is a similarity between all cases, but the symptoms and the severity of each symptom vary quite widely. There are no two cases exactly alike. And this can affect men, it could affect women. It's a little more common in men. It's around the world. There are cases of Parkinson's disease in every continent and in every society. You see it in Japan, you see it in China, you see it in Africa, you see it all throughout Europe. It's a worldwide condition. Next slide, please. And as I mentioned, as far as just the motor symptoms, there's no two cases alike. Some people have no tremor, but they're just sort of stiff and slow and rigid. Other people have a lot of tremor, but they're not so slow and rigid. Most cases have a little bit of everything, but not only are the motor symptoms different from case to case, but we're going to talk about some of the non-motor symptoms that are very important, that are also variable from case to case. Next slide, please. So when you see a new patient, this was actually, I omitted this. So does everybody who has some of these Parkinsonian signs definitely have Parkinson's disease? And the answer is no. Next slide. Because there are other neurologic conditions that could potentially mimic Parkinson's disease. There are other neurodegenerative diseases that early on have some symptoms that look Parkinsonian. So sometimes your initial diagnosis may have to be revised. The one thing, though, I think this audience has to always keep in mind is that there are medications that can cause Parkinsonian symptoms that look like Parkinson's disease. What are those medications? Those are your neuroleptics. The first generation neuroleptics, but even the second and third generation neuroleptics all have the potential of causing Parkinsonian symptoms, which shouldn't be confused with Parkinson's disease, because when those neuroleptics are withdrawn, the Parkinson's symptoms will eventually resolve. So that's very important to keep in mind. Next slide, please. So what treatment is recommended for every person with Parkinson's disease? Next slide. Exercise. And I want to emphasize the importance that people with Parkinson's disease who exercise regularly, if you follow them 5 and 10 years later, as a group, they are doing much better. But we shouldn't underestimate the important social and mental health benefits of exercising with other people. And sometimes patients and families learn more from other persons with the condition than they learn from their doctor. So the social aspect as well as the physical aspect, very important. Next slide. And luckily, here in Maryland, here in the Baltimore region, we have 2 wonderful charitable organizations that sponsor a wide range of free exercise programs, including boxing, dancing, singing classes, art classes, exercise classes, as well as support groups. And I'm referring to the Maryland Association for Parkinson Support and the Parkinson Foundation of the National Capital Area. And these are wonderful organizations and have terrific free resources for your patients and their care partners. Next slide, please. Now, I've always found it's often easy to get patients to take pills, but getting them to actually participate regularly in exercise sometimes takes some cajoling, particularly if people aren't used to exercising throughout their life. So there's no one exercise program that's right for everybody. It has to be fitted to the patient's own physical abilities and disabilities. But I try to remind people that this is a commitment and that effort isn't always rewarded, but lack of effort is never rewarded. And I really feel that people need to participate in these programs if they want to do better in the long run. Next slide, please. So what's the best medicine, or is there a medicine for treating Parkinson's disease? And we're going to go quickly through the next few slides because I had omitted some of these in the next slide, please. So, but to understand the medications, we have to sort of step back a little bit. How were these medicines developed? So it turns out there's a part of the brain called the striatum. What is the function of the striatum? This is the part of the brain that facilitates complex sequences of movements. So when you're walking, you have to pick up the feet in the right sequence. When you're writing, your hand has to hold the pen in exactly the right movements have to be sequenced. So that's the function of this area called the striatum. And I like to, it's like the symphony orchestra and the conductor. The conductor isn't playing the music, he or she is making it more rhythmic, smoother. And that's what this part of the brain does. It sort of smooths out movements to make them occur efficiently. This is the part of the brain that's malfunctioning in Parkinson's disease. Next slide, please. And it turns out that back in the 1960s, a new neurotransmitter called dopamine was discovered, and it turns out that dopamine was a very important neurotransmitter in the striatum, this part of the brain that's malfunctioning in Parkinson's disease. Next slide. And it turns out, remember I showed you that slide, the pathology slide, those neurons in the midbrain that were degenerating and disappearing, those are the cells that were producing dopamine and transporting it to the striatum. Next slide. And back in 1969, there were many doctors who were saying, well, maybe if we replenish dopamine, we could make Parkinson's better. And for sometimes it seemed to work, sometimes it didn't. There was a brilliant man named Dr. George Coetzee who really studied it carefully over months and dozens of patients and discovered this was definitely helpful for people with Parkinson's disease. Levodopa replenishes brain dopamine. It was a miracle. And I was in medical school. I saw the first patients who received levodopa, and it was a miracle. People who were totally disabled, they were rigid and slow, suddenly can get up and start walking. And this is very similar to insulin and diabetes. Insulin is not a cure, but it miraculously helps the sugar regulation. Levodopa is not a cure. It doesn't stop neurodegeneration, but it really helps the symptoms. The motor symptoms improve, and the benefits persist throughout the course of the disease. But unfortunately, as you'll see as time goes on, the neurons in other areas of the brain continue to be affected. Next slide. So all patients with Parkinson's disease improve on carbidopa, levodopa. There's no one dose that's right for everybody. It's just like there's no one dose of insulin that's right for every diabetic. You have to titrate the doses, monitoring, is the stiffness getting better? Is the writing getting better? Is the walking getting better? How are the target's symptoms responding? And adjust the dose accordingly. And there's a wide variation in how much medicine people need. We have to monitor for side effects. So obviously, we don't want to over-medicate people. We don't want to under-medicate people. Next slide, please. And the goal of treatment, I guess you could also make an analogy to diabetes. You can't always make all the symptoms better all the time. The realistic goal is to keep people functioning in the mainstream of life. And we are very good in getting better at doing that. People with Parkinson's disease can lead pretty active, normal lives for many years after diagnosis if properly treated. Next slide, please. So levodopa really was a miracle drug. I think we sort of take it for granted because it's been around now for over 50 years. It certainly changed things, but it didn't solve all the problems. So what can go wrong over time? Next slide. Well, one of the first things that goes wrong is the fact that the benefits of the disease could fluctuate throughout the day. And I'll show on the next slide that the longer people have Parkinson's disease, the more difficult it is for the brain to store the medication. So you're giving the pills maybe 3 or 4 times a day in divided doses, but between that time, the levels in the brain may go up or down, so the patients might become under-medicated and slow down and have trouble walking and trouble with more stiffness and shaking. And at other times of the day, the levels may even be too high. So this fluctuation is very disabling because it disrupts the flow of life. You can't make plans if you don't know if you're going to be walking well or not walking well. Next slide. And I won't go into this slide other than the fact that in addition to carbidopa, levodopa, there are a variety of other medicines that can be used to try to smooth out those fluctuations. You can see how complicated these medical regimens might get. So people may end up taking the medicine every 3 or 4 hours around the clock. So if compliance is challenging, there's side effects of polypharmacy. Now, on the next slide, this is particularly a problem if the Parkinson patient, for example, gets hospitalized due to pneumonia or due to a heart attack or for some medical condition. I mean, Parkinson's itself really doesn't get people into the hospital, but medical comorbidities or surgical comorbidities can lead to hospitalization. And what happens in the hospital is people who have these complicated medication regimens don't get their medicines on time or they don't get the right doses in the hospital. And sort of, so it's so key that medicines have to be given on time, every time, to avoid these patients developing serious motor complications in the hospital. And I think since most physicians who are hospitalists or working in hospitals may see just a couple of Parkinson patients a year, they don't appreciate this. And there's all sorts of complications that could be avoided if they realized how crucial, just like if somebody were hypoglycemic, you wouldn't wait 2 hours to give them some sugar. When people are on these complex medication regimens, you have to give their medicines right at the time that they need it. Next slide. Now, you've probably heard of some of these new invasive surgical treatments for Parkinson's disease, so-called deep brain stimulation, where an electrode is put into an area of the brain. And there's an infusion pump that's actually placed, the tube is placed right into the jejunum to deliver a continuous supply of levodopa. Both of these are very successful surgical interventions for reducing motor fluctuations in some of these very complicated patients. Next slide. What else could go wrong? Well, the dopaminergic medications aren't innocuous. Next slide, please. And just like there may be times when the medication levels in the brain are too low, sometimes it could be too high. Now, the next slide, if our video had been working, would be showing Michael J. Fox rolling and dirtling and not sitting still. And that isn't Parkinson's tremor. That's what's called dyskinesias, where patients are a little over-medicated or oversensitive. They get these bizarre involuntary movements where they literally can't sit still. So that's a side effect of medication. Likewise, too much medication can trigger hallucinations, delusions, frank psychosis, and impulse control disorders, where people develop terrible destructive behaviors like excessive gambling or even hypersexuality or hoarding behaviors related to excessive dopaminergic stimulation of certain areas of the nervous system. Next slide. So we have to be very aware of these possible complications. Unfortunately, the lack of dopaminergic neurons in the brain, although it's what people seem to talk about all the time, is certainly not the only thing that's going on in the brain. Other systems in other areas besides dopaminergic areas might become affected, leading to what we call non-dopaminergic motor problems, or problems of movement that aren't related to the lack of dopamine and thus aren't helped by our deep brain stimulation or by our medications. Next slide. And these could be quite disabling. People have freezing of gait where their feet feel like they're stuck to the floor, like almost by magnets, and they just can't pick up their feet. Or once they start walking, suddenly they stop and they start tilting forward, like in this picture. Painful dystonic rigidity where the muscles are so stiff they become stuck in one spot with rigidity. Of great morbidity is the fact that if swallowing can become affected, so people can get severe what we call dysphagia, difficulty swallowing, and they can aspirate, get pneumonia, slurring of speech, sometimes becoming unintelligible. These are all non-dopaminergic motor problems that can occur many years after diagnosis. And once again, fortunately, we have speech therapy, we have physical therapy, we have ways of trying to get around these problems, but these are not problems where medication or surgery is likely to help. Next slide, please. But I think probably of greatest interest to this audience is in terms of what else could go wrong. And although we call Parkinson's disease, that's the next slide, please. What we call Parkinson's disease a movement disorder because it's diagnosed based on abnormal movements. The abnormal movements are just the tip of the iceberg. There's a lot that goes wrong that's not related to how the person's moving. Next slide. In fact, in many patients, these non-motor problems are the major source of disability, not the movement problems, because we have some pretty good treatments for these movement problems in general. There are some major psychiatric and behavioral problems that can accompany Parkinson's disease. There's cognitive issues that might occur. There's problems with the autonomic nervous system, controlling blood pressure, bowel and bladder. There's a variety of sleep disturbances. So let's have the next slide, please. So just about this autonomic dysfunction, many persons with Parkinson's disease have trouble regulating their blood pressure. So when they stand up, they have what's called orthostatic hypotension. The blood pressure drops and they become very lightheaded. They could even fall down and faint. Problems with bowel function, severe constipation, the problem with Parkinson's disease, bladder dysfunction, sexual dysfunction, severe fatigue, all reflect problems with the autonomic nervous system. And for many patients, these are worse symptoms than a little bit of tremor. Next slide. Think about these behavioral changes. So there's certain behavioral changes that might occur at any time during the course of Parkinson's, even before the diagnosis. For example, depression. Significant depression is very common in Parkinson's disease. And in fact, as most of you know, sometimes depression can begin even before the diagnosis of Parkinson's disease is made. Depression is often a warning sign that the patient, late life depression is often a warning sign that the patient's developing a neurodegenerative process. Anxiety, very significant problem for many Parkinson patients. Once again, sometimes occurring right at the onset of the disease, often accompanying depression. Apathy, terrible problem. Just loss of motivation, loss of interest, lack of concern, terribly disabling. Once again, sometimes accompanying depression, sometimes occurring by itself. Mild cognitive impairment often is present at the time of diagnosis. Later in the course of the disease, of course, patients often can develop significant dementia, often accompanied by psychosis, severe visual hallucinosis, delusions, episodes of delirium. So, as you could imagine, how disabling all of these different non-motor features can be for certain persons with Parkinson's disease. Next slide, please. So, are cognitive issues or dementia inevitable in persons with Parkinson's disease? Next slide. Well, at the time of diagnosis, anywhere between 10 and 20% of persons with Parkinson's disease might have mild cognitive impairment. Interesting, though, if you follow those patients over the next 5 years, some of those patients will actually develop dementia, but interestingly, some of those patients will actually return to normal cognition. And whether that's related to the dopaminergic therapy or just, it's a little controversial. The natural history of mild cognitive impairment in Parkinson's disease, yes, it is often a prodrome of dementia, but sometimes it's not. Something that's very common and disabling in Parkinson's disease is bradyphrenia, slowness of response. Sometimes patients who aren't confused just have trouble organizing their thoughts efficiently so that their responses are very slow. It's sort of the psychic equivalent of slowness of movement. And when these people are slow of thought, they often go to a party or try to socialize, and they never get a word in edgewise because people are talking about topics rather quickly, and they just can't get their thoughts, and they basically get excluded. It's very demeaning phenomenon for patients with bradykardia that they just can't really participate. Of course, bradykardia is often a phenomenon accompanying Parkinson's disease dementia, but not all these patients who are slowed mentally are necessarily demented. And of course, with dementia, you have these terrible psychotic features in many cases with hallucinations and delusions, with memory and language being relatively less affected than one would see, for example, in Alzheimer's. I mean, there's a pretty clear distinction between Parkinson's disease, dementia, and Alzheimer's disease. Unfortunately, sometimes the two conditions could even coexist. But is it inevitable in Parkinson's disease? I think if you follow a person with Parkinson's disease for 20 years, there's a very high probability that after 15 or 20 years there will be dementia. But since most cases might begin at age 65 or so, patients could have many excellent years before dementia ensues, and it's certainly not inevitable in every case. Next slide, please. So it's important to emphasize that teamwork is crucial in managing Parkinson's disease. You need a neurologist who's experienced with how to use these different medications and the indications for things like deep brain stimulation. You need a good internist to help handle nutritional issues, constipation issues, help with orthostatic hypotension. You need to work with a physical therapy, occupational therapy, speech therapy. Clearly, the patient and their spouse or care partners might need help with counseling and psychiatry, social work, et cetera, et cetera. So it does take a good team effort. And next slide, please. But the good news is, with appropriate treatment, most patients with Parkinson's disease do remain in the mainstream of life for many, many years after the diagnosis. And, although we don't have a cure, Michael J. Fox always comments, he says, Parkinson's disease is no cure does not mean that there's no hope, because we can keep most people pretty active in the mainstream of life for quite a while. Next slide. But what about the poor care partner? Because people who've had Parkinson's for a number of years do need help. And it's often the spouse or other family members. And they're often the neglected piece of this puzzle. I always tell my care partners, whatever you do, don't drop out of the mainstream of life yourself. But what else can we do to help the poor care partners? Next slide. So it turns out that something I hear from many care partners dealing with someone who's had Parkinson's disease for 10 or 15 or 20 years, who's having major motor problems, they'll say, gee, I can deal with his difficulty moving around, but I can't deal with his behavior. So when these psychiatric problems with severe depression or psychosis and dementia become prevalent, this is what often leads to nursing home placement in Parkinson's disease. The neuropsychiatric problems and the sleep disturbances have a tremendous impact on care partner burden, more so sometimes than the motor symptoms. Next slide. So once again, we need that team approach. How can we reduce the stress on the care partner? Clearly engaging family and adult children to pitch in and help. And I always tell families, don't, kids always say, I'll help whenever, just let me know. No, you should set up a regular schedule. You need a commitment. Every Saturday, you're going to be here for 3 hours. Or, you need to have that commitment rather than make it nebulous. And of course, the help of neighbors, friends, religious groups, sometimes paid companions, home health aides, adult daycare programs, all very helpful. But I underline the role of support groups. Those two charities, the Maryland Association for Parkinson's Support and the Parkinson Foundation of the National Capital Area, have sponsored wonderful support groups. And so many of my care partners and spouses tell me they've learned so much from talking with other persons going through similar things, that this has been a lifesaver. And clearly, counseling and psychiatric intervention or psychological counseling or pastoral counseling, very helpful for care partners. And if things are really tough, even getting some temporary respite care could be quite helpful. Next slide. And I think I'm going to, in the interest of time, quickly go through this. Why does this happen? What causes Parkinson's disease? Next slide. Get through this quickly, I hope. Well, here's something very interesting that we just learned over the last couple of decades or so. There are symptoms that precede those abnormal movements that allow us to diagnose Parkinson's disease. There are symptoms that precede that by many years. The most important of which is something called REM sleep behavioral disorder. Next slide, please. Now, it's a shame these videos aren't playing. The video would have shown this gentleman is in a sleep lab being monitored. He's in deep sleep, what we call REM sleep, stage 4 sleep. And he starts punching and kicking. And if somebody had been in the bed next to him, he would have slugged him in the face. Because normally during REM sleep, movement is inhibited. People are totally motionless, but that part of the brain that inhibits motion during REM sleep is actually damaged before those neurons in the midbrain that lead to the Parkinson motor symptoms. Now, next slide, please. And realizing that has led to a whole new concept of Parkinson's disease. The fact that the disease doesn't necessarily begin in those midbrain neurons, but may begin lower in the nervous system, perhaps even coming from neurons in the gut. And what's happening? About 20 some years ago, they discovered that the main protein in those Lewy bodies, those little inclusions in the neurons that are malfunctioning, are made up predominantly of a protein called alpha-synuclein that's misfolding and it's spreading throughout the brain. And depending on where it is spread, determines what type of symptoms you're going to have. Next slide, please. So why is this protein misfolding? Well, age has a lot to do with it, but it turns out there are a variety of genetic predisposing factors. Now, very few patients with Parkinson's disease have a family history where, gee, my father had it and my grandfather had it. You know, this autosomal dominant and autosomal recessive forms of Parkinson's disease they occur, but maybe that accounts for 5% of all cases. So there are certain genetic mutations that will lead to Parkinson's disease, but they're rare. It turns out there's some much more common genetic variants that increase the risk of Parkinson's. The most common being glucose cerebrosidase type 1, the genetic abnormality that, if present in both parents, would lead to what's called Gaucher disease. And it used to be thought that if you inherit from just one parent, you're going to be fine. It turns out that people who inherit one abnormal glucose cerebrosidase type 1 gene have a considerably increased risk of Parkinson's. Remember I mentioned earlier that at age 70, about 2% or so of people have Parkinson's disease. If you have one of these GBA1 variants, instead of having a 2 or 3% risk of Parkinson's disease, you probably have a 6 to 10% risk of Parkinson's disease. So it's quite so there's a series of genes that don't cause a 25 or 50% risk or 100% risk, but may increase the risk of Parkinson's several-fold. Next slide, please. So we now know that there isn't such a thing as Parkinson's disease. They are Parkinson diseases. There's many different causes. There's many different genetic factors. There are many different environmental factors that might allow these genes to express themselves. So it's a combination of aging, genetic predisposition, perhaps some environmental triggers, and epigenetics, all of which pull the trigger. But it's not just one specific disease. So I've put a lot on your plate. Next slide, please. And if you'd like to read more about this, I will be glad to email any of you a free copy of my Parkinson primer that covers all of these topics. If you send me an email with your email, I'll gladly send you this this book. But in any case, I hope we still have some time for questions. I'm going to run too long. And
Dr. Weiss, if you wouldn't mind emailing that to me, I can post that on our website with this presentation as a resource for folks that have attended.
yeah, I'd be glad to. I thank you, and I'd be delighted to do that.
Thank you.
Thank you so much, Dr. Wise. Does
Um,
anyone have any questions or any comments that they'd like? I have one that I'm going to bring up is you mentioned something about the gut biome. And you're hearing more and more about the gut and how it connects to other health issues.
No.
Is there research being looked at in that regard? Do you know?
This whole thing is it's exploding, Jane. And it turns out, I talked about that little protein alpha-synuclein that seems to misfold and it damages the neurons in the midbrain, which causes the lack of dopamine, which causes people to develop the motor symptoms. So they have found misfolded alpha-synuclein in the colon and in the small intestine. And there's a school of thought that believes that a goodly number, not all patients with Parkinson's disease, but in many patients with Parkinson's disease, that's where the alpha-synuclein is folding. And it might be, so what causes it to start misfolding in the gut? Is it something in the microbiome? And the answer, and if you have that GBA1 mutation, are you more prone to be sensitive to microbiome changes? And there's a school of thought that believes that's where Parkinson's begins and then travels up the vagus nerve and ultimately gets into the lower brainstem where it causes REM sleep behavior disorder, and then eventually travels up to the midbrain where it causes the motor symptoms. And there's another school of thought where, so I didn't mention it in interest of time, but for many people there's a loss of sense of smell. And in some patients, the thought is that the misfolding actually begins in the olfactory nerve and then spreads into the brain. So there's two different avenues where this misfolding may begin, but the microbiome might be playing a role early on in triggering this misfolding.
Yeah, interesting. There seems to be a lot of things that are looking at microbiome and the impact on health. So that's an interesting point. Thank you. Does anyone else have a question? You can unmute if you'd like. I do think the challenge of the medication regime is often a challenge for caregivers as well as staff if the patient is in some type of facility. So I am glad that you brought that point up.
Jane, it's interesting because people who've had Parkinson's for many years often have to take medicines 4, 5, 6, even 8 times a day. And you'd think it's impossible. But I've always been amazed how compliant many of the patients were because they feel the benefit and they want to take their medicines on time, but they often have to use timers, and it is very complicated. And thankfully, we have some newer medicines on the market now that have longer half-lives so that instead of taking it 8 times a day, they can maybe get away with 4 or 5 times a day. But I've always been amazed how patients would try to be compliant, unlike other diseases where you have to twist people's arm to take a pill once a day.
Dr. Weiss, can you speak at all about the use of cannabis for Parkinson?
Yes. So it's really interesting. I mentioned anxiety can be a major problem in Parkinson's disease. And I think for some patients, cannabis might have a bit of an anxiolytic effect. So there may be a benefit in that sense for some patients. I don't think there's any particular benefit for motor function per se, other than the fact that anxiety, for example, makes motor function worse. So it's a vicious cycle in that respect. Pain, unfortunately, can be a problem in some patients with advanced Parkinson's disease. I mentioned severe dystonic pain, and cannabis might have a role to play in those patients who are having severe pain in Parkinson's disease, and certainly painkillers aren't of any particular benefit. So there might be a role for some patients. Unfortunately, as you know, research on medical uses of cannabis is just not being well supported, and there's a lot of mysteries. But I think there might be a role for some patients.
Thank you.
Well, if there's no other questions, we would like to again thank you so much for this interesting presentation. And watch out now, we're going to invite you back.
Yeah.
And I appreciate everyone who's attended today. We welcome you next month as we continue our series. We're going to hear from one of our geropsychiatrists, Dr. Buhala, on the non-Alzheimer's dementias, understanding them. And so we look forward to all of you coming back, and we wish you a wonderful weekend. It's supposed to be sunny and warm, so we're thankful for that sunshine. Thanks again, Dr. Weiss.
I do want to share the resources that we have available. I will be posting this recording on the Living Well website, as well as sending out invitations for the May event. And I will also post the PowerPoint and the primer that Dr. Reese can share with us as well. And if you have any questions, concerns, or topics of interest that you'd like us to host, please make sure you reach out to either Jane Marks or myself, and we'll be happy to address your questions. Thank you all again for attending. Thank you again, Dr. Weiss, for presenting to us today. Great. And